Hello everyone. I work at Bakırköy Hospital of Psychiatric Diseases. I'll be talking about mood stabilizer use during pregnancy. Bipolar diseases normally start at the onset of late teens. Anticonvulsionary agents and anti-pregnancy medicines can interfere with mood disorders. Therefore, intrauterine devices are advised for use. In the previous years, there was a claim that pregnancy may improve bipolar disorder. However, we see that there's a high risk of manic episodes, depressive episodes, mixed episodes during pregnancy. With many bipolar patients, we actually see that manic episodes, depressive mixed episodes can be triggered during pregnancy. Prematurity, low birth weight, and small gestational age are a high risk for women with BPD compared to healthy subjects. Therefore, it's important for these patients for pregnancy to be planned. It's good to wait for a 1-year healthy period, during which time a review can be undertaken for the patient and the partner. The teratogenic effects of mood stabilizers need to be monitored, and the patient as well as the family need to be informed. For many patients, there can be a decision to suddenly stop or discontinue the treatment. This results in recurrence, i.e. the sudden interruption of mood stabilizers can trigger a recurrence. It's better recommended to decrease the dosage gradually. In a study, after sudden interruption of mood stabilizers, the risk of mood episode is shown as 100%. For those who continue using lamotrigine, this goes down to 30%. When we look at the markers, we see that might be used. These are some of the markers that might be used for interpretation of recurrence: BPD type 2, early onset of disease, unplanned pregnancy, multiple episodes in a year, the history of a new episode, and antidepressant use, as well as use of anticonvulsants instead of lithium. When planning for pregnancy, if possible, the dosage needs to be reduced gradually in a period no less than 2 months, which would then give us some time to assess whether inflammation takes place or recurrence appears. There are some factors to pay attention to during this time when using mood stabilizers. First of all, the prognosis of PPD, symptoms profile, suicide risk, treatment type need to be considered. Also, the results of discontinuance of mood stabilizer in the past need to be taken into effect. Usage in the first trimester, like Ms. Shada has mentioned, need to be taken on a benefit and loss basis. Let's have a look at mood stabilizers and breastfeeding relationship. It's quite a sensitive period, because breastfeeding is very important. We don't want to let it go. It's a protective, it has protective benefits for the babies, for atopic dermatitis, for asthma. It also affects the mother against ovarian cancer and breast cancer. Therefore, There needs to be a serious pros and cons consideration for the mother as well as the baby. The evaluation of the course of disease, efficacy of drugs used, the risk of recurrence need to be taken into consideration. In addition, we need to pay attention to the birth time as well as the accompanying developmental anomalies, if any, for the baby. If there are any developmental or metabolic anomalies, then further side effects might be experienced. This is the ACOG classification. Lithium, valproate, and carbamazepine is category B. Lamictal is category C. Lithium is L4. When we look at the mood stabilizers, 4 parameters are extremely important during breastfeeding. The half-life, T1 over 2, maternal plasma protein binding, milk plasma ratio, and oral bioavailability. The higher the half-life, of course, higher the risk. We also need to consider that if MP ratio is higher than 1, that suggests that the drug concentration is higher than the acceptable level of adverse effect for the baby. The dosage baby is exposed can be calculated by the distribution of the drug in fat tissue, the dosage used, the metabolism of the mother, as well as the peak concentration of the drug in the milk and the bioavailability for the baby. Lithium, for a long time, is a drug that we try to refrain from using during pregnancy. Of course, planned pregnancy and discontinuance of lithium until a month before pregnancy are important. We need to check BHCG regularly. Discontinuance of lithium for the first trimester and beginning again in the second trimester for lithium maintenance treatment is important. If that is a necessity, I mean, if lithium needs to be used, it needs to be the lowest dosage. Attention needs to be paid for hydration during pregnancy, especially for hyperemesis gravidarum. If GFR increases, then the regulation of the dosage is extremely important and necessary. We need to check lithium regularly before delivery, decrease dosage to 30 to 50%. If we use lithium in the first few months of pregnancy because of the Epstein risk, we need to, during the second trimester, a fetal echocardiography and ultrasonography. This needs to be high resolution ultrasonography. We also need to pay attention to hyperemesis or gravidarum. Also, starting from birth, there might be decreases in hydration. In order to refrain from toxic effects of such lower hydration, we need to reduce the lithium dosage to 30 to 50%. If there will be C-section, we need to stop treatment 2 or 3 days before the C-section. It's important to discontinue lithium use 48 hours before the delivery, and also during pregnancy and after delivery. It's important to ensure that there is a high level of hydration. Non-steroid anti-inflammatories and other nephrotoxic agents need to be not used. In a study, women with bipolar disorder who stopped using lithium due to pregnancy had a 2 to 9 times higher risk of postpartum episode than non-pregnant women. The prevalence of Epstein's anomaly is 1 to every 20,000, and polyuria and polydipsia in mothers is related to lithium use during pregnancy. As pregnancy progresses, GFR increases and lithium excretion also goes up. During the perinatal use of lithium, of course, the benefit-safety ratio is a still favorable parameter to assess. If the disease is an attack period, if lithium is the only drug to resort to, then it can be considered. However, it increases an attack in postpartum period if lithium is discontinued suddenly. As we have said, this increases the risk 2 to 9 times higher. The prevalence of Epstein's in normal population is 1 to 20,000. With lithium use, this increases 20 to 40 per 20,000. Still low, but not a very significantly high ratio. The most risky period is between the 4th and the 9th months. If there is lithium exposure during this time, a high-resolution ultrasonography and echocardiography need to be taken. In the postpartum period, for mothers and babies, lethargy, arrhythmia, difficulty in breathing must be followed or monitored as potential risks. If there is long hospitalization of babies or central nervous system adverse symptoms, then they need to be taken seriously as well. For babies who have been exposed to lithium during the pregnancy, day 1, day 3 and day 9, serum lithium levels need to be calculated, and also EKG needs to be taken. There is only one study looking into the long-term effects of lithium. Bedwetting and stubbornness have been observed, but not statistically significant levels. This is an area that we need to look further in. Breastfeeding and lithium. Like I have said, lithium exposure in newborns might cause hypotonia and lethargia. AAP suggests that it is not absolute indication during pregnancy. There are some studies about breastfeeding and lithium exposure, and the rule of halves is used. Lithium level of milk is the half of lithium level of mother plasma. Lithium level of baby plasma is the half of lithium level of milk. Therefore, we need to follow the lithium levels once a week for the first 6 weeks, and then later once in 2-3 weeks for the remainder time. In a study, it was found that the baby's serum lithium levels was 10 to 17% of that of the mothers. If we are to use lithium in the mother, this is how the management of lithium treatment during pregnancy needs to be done. In the second 3 months, once every 2-3 weeks, and then it needs to be monitored for assessment of the functions for potentially affected organs, so that we can monitor the lithium levels, and also renal function tests need to be undertaken. Valproic acid. Particularly in the first trimester, when valproic acid is used, there might be some defects in the baby, up to 5 to 9% of all cases. Spina bifida occurrence is 0.05%. However, this goes up to 0.6% with valproic acid use. In order to reduce the risk, folic acid preparations are recommended for use before and during pregnancy. However, this is a theoretical piece of information. The real effect is still not known. For valproic users, the risk is 0.5%. For cough pellet, it's 0.3%. Opus is 0.7%. Polyactory, 0.2%. And for all congenital malformations, it's 6.2% to 16%. In terms of congenital malformations, and particularly for neural tube defect, if the pregnant woman is using valproic acid, we need to ask specifically the date of the last cycle. This is a question that needs to be asked to all pregnant mothers-to-be. VPA used during pregnancy might cause lower IQ up to 9 percentage points, as found by a study. Congenital malformations occur particularly if VPA is used above 1000 milligram daily dosage. So malformation emergence is or can be linked to the dosage level per day. ANA advises VPA during breastfeeding. VPA users during pregnancy who continue 1600 mg per day during breastfeeding might experience anemia. And also, serum levels of two mothers who use VPA have had 1.5% to 6% of VPA levels, and in the same study we see that baby serum levels were roughly 0.9% to 1.5% of that of the mothers. So it's important for these pregnancies to be planned pregnancies. If the mother is a VPA user, if it's clinically a necessity, it can be continued. Otherwise, we need to refrain from VPA use, particularly for the first trimester and also for the remainder of the pregnancy. It's recommended that the woman uses 5 milligrams of folic acid. VPA should not go above 1000 milligrams, because above that level the malformation risk increases. Malnutrition. As per findings from the epilepsy studies, it is deemed to be a safe anti-convulsion agent. In clinical practices for malnutrition, a standard therapeutic dose doesn't exist, therefore malnutrition monitoring becomes very difficult. However, during pregnancy use, compared to other agent, it has lower risk for the fetus, so that's deemed to be an advantage. In terms of malformation risk, it ranges from 2.7% to 7%, particularly in the first 3 months. Within the 6 to 9 weeks of the pregnancy is deemed to be a critical period. In a study, it's found that there is no teratogenic effect that caused those malformations. In a more recent cohort study in Denmark, malformation risk is calculated to increase by 1.8 times. However, this is not deemed to be statistically significant. It's recommended that the dosage is kept max at 200 milligrams to prevent any malformation risk. Classification is L3. In a retrospective study, during the 2nd and 3rd trimesters, it is observed that there's a 100 to 150% increase. However, with the delivery, hepatic activation comes down and metabolic speed also reduces. If you could please change the slides so we can follow better. And this increases the lamotrigine levels. Newport and colleagues have done a study in 2008, and lamotrigine using mother's milk plasma level was calculated as 43% and reached this level at the 4th hour. Antenatal and postnatal periods and Johnson syndrome might be observed. Therefore, lamotrigine use is not recommended. Carbamazepine. Recommended only if other mood stabilizers can't be used during pregnancy. It was also observed that there's an increased risk of spina bifida, 2.6 to 4.2 times higher than the normal population if carbamazepine is used during pregnancy. So, compared to PAPA, it's a lower risk, however, there's still a risk. Total risk is 3.3% with respect to all anomalies. It might also cause vitamin K deficiency, or there might be a higher bleeding risk in the newborn, and additional vitamin K administration to the baby at the level of 1 milligrams per day is recommended. During pregnancy and the first 5 weeks of breastfeeding, polycystic hepatic cases are observed in some patients in 50 to 80% of the mothers. American Neurological Society suggests that carbamazepine can be used during pregnancy. During breastfeeding, liver function tests need to be undertaken both for the baby and the mother in the 16 to 18 weeks of pregnancy. Alpha fetoprotein measurements in the amnio fluid needs to be measured. Oxazepine. Active metabolite is 10-oxy-CB. When compared to carbamazepine, it's deemed to be safer. If an anti-epileptic mood stabilizer is to be used during pregnancy, here is the management parameters. A very close monitoring of the agents, thyroid function test, renal function test, liver function test, also for cardio functions in the second trimester. Certain tests need to be undertaken. In summary, we should say that we need to inform all women about contraception and ask the last menstruation date if BPD is a part of their story. Of course, planned pregnancy is advised. Switching should be done until or before pregnancy. The period of rhythmic moods should be at least for 3 months before the start of pregnancy. Of course, informed consent should be taken from both the mother and the father after briefing about the risks of the usage of drugs during pregnancy. This is very important. There needs to be a written consent form. Switching of the drugs should be done very slowly, gradually. Sudden interruption should be avoided because it increases the risk by 9 times. Minimum dosages should be advised. And we should advise polytherapy, monotherapy should be adopted. Anamnesis and the clinical characteristics, like seasonality, types of mood episodes, suicidality of the patient need to be evaluated. FDA classification and current literature should be followed for the decision of the type of mood stabilizer. Dysregularity of sleep cycle during perinatal period should be taken into account for the risk of recurrence. Cooperation with obstetrician and pediatrician, multidisciplinary approach are important. It also needs to be coordinated with the family members in an effort to keep them alert. The dosage of the drug should be minimum and divided in equal dosages before and after pregnancy. PCOS concentration and half-life of the drug should be taken into account. Family should be informed that supplementary food may decrease the relative dosage of mood stabilizers, particularly after the 6 months. And the family should be advised about potential side effects. Thank you very much for your kind attention.